How would you respond if a patient who has a history of trauma becomes triggered by a routine procedure?
Responding to a patient with a trauma history who becomes triggered during a routine procedure requires immediate recognition, a trauma-informed approach, and skilled de-escalation. My first priority would be to promptly identify the signs of a trigger, which might manifest as sudden anxiety, agitation, withdrawal, or an immediate change in body language. At that precise moment, I would immediately halt the procedure to prevent further distress and potential re-traumatization, ensuring both the patient's and my own safety. Following this, I would prioritize creating a calm and safe environment. This involves reducing any external stimuli, such as dimming lights if appropriate or moving to a quieter space, and ensuring the patient feels secure. I would then approach the patient calmly, making eye contact if culturally appropriate, and speak in a soft, reassuring tone. My communication would be empathetic and validating, acknowledging their distress without probing for details of their trauma in a moment. Phrases like, "I can see you're feeling distressed right now, and it's okay. We can take a break," would be essential. Central to this response is offering the patient control and choice. I would ask them what they need at that moment, perhaps a glass of water, a few minutes of silence, or if they would prefer to reschedule or approach the procedure differently. Empowering them with choices helps to counteract the sense of helplessness often associated with trauma. If appropriate, and if the patient is receptive, I might gently suggest a grounding technique, such as focusing on their breathing or identifying objects in the room to help bring them back to the present. After the immediate crisis has subsided, I would collaborate closely with the interdisciplinary team, including the psychiatrist or therapist, to review the incident. This allows us to adjust the patient's care plan to incorporate specific triggers and preferences for future procedures, perhaps including pre-procedure preparation or an alternative approach. Documenting the event thoroughly, including the triggers, interventions, and patient's response, is crucial for continuous individualized care. Ultimately, my goal is to ensure the patient feels respected, understood, and safe, fostering trust that is vital for their healing journey.
Describe how you would approach a care plan for a patient with a dual diagnosis of a severe mental illness and a substance use disorder.
Addressing a dual diagnosis requires a holistic and integrated care plan that simultaneously addresses both the severe mental illness and the substance use disorder. My initial approach would be to conduct a comprehensive assessment that goes beyond a standard intake. I would explore the patient's full medical history, substance use patterns, and psychiatric symptoms, and critically, how these two conditions interact and influence each other. For instance, is the substance use a form of self-medication for their psychiatric symptoms, or is it exacerbating their mental health condition? Understanding this dynamic is crucial for effective treatment. Following a thorough assessment, I would collaborate with the interdisciplinary team, including psychiatrists, therapists, social workers, and addiction specialists, to create an individualized and coordinated care plan. The core of this plan will be the principle of integrated treatment, meaning both disorders are treated concurrently rather than sequentially. This involves prescribing and carefully monitoring psychiatric medications to stabilize their mental health symptoms while also implementing evidence-based therapies, such as motivational interviewing and cognitive behavioral therapy, CBT, to address the substance use. The care plan will be patient-centered, incorporating the patient's personal goals and motivations for recovery. Throughout this process, building a strong therapeutic rapport with a patient is paramount. I would use non-judgmental and empathetic communication to foster a sense of trust and safety. The plan would also include harm reduction strategies to minimize risks associated with substance use, even if the patient is not yet ready for complete abstinence. Education is another key component. I would educate the patient and their family on both conditions, treatment options, and the importance of adhering to the care plan. Regular reassessment would be essential to track progress, manage potential setbacks, and adjust interventions as needed, ensuring the care remains dynamic and responsive to the patient's evolving needs.
A patient you have been building rapport with asks you for your personal phone number or social media handle. How do you respond and why?
When a patient asks for my personal contact information, my primary response is to maintain professional boundaries while preserving the therapeutic relationship. The first thing I do is acknowledge the patient's request directly and politely. It's crucial to avoid a dismissive tone, as that could damage the trust we've built. I would explain that, for professional reasons and to ensure their care is managed within a secure, clinical framework, I cannot share personal contact information. This maintains a safe and predictable environment for them. I would say something like, I really appreciate that you feel comfortable enough to ask. Because I'm your nurse, my role is to support you here in the clinic, and our policy requires that all communication happens through official channels to protect your privacy and ensure you receive the best care from our entire team. The why behind this response is rooted in both professional ethics and patient safety. Sharing personal information creates a dual relationship, blurring the lines between a professional and a personal connection. This can compromise the objectivity of care and, more importantly, put the patient in a vulnerable position. They may feel they can only contact me and not the rest of the care team, or they might feel obligated to maintain the relationship outside of a professional context, which isn't fair to them. Furthermore, it safeguards my own personal privacy and professional integrity. To ensure the patient still feels valued and supported, I would then offer them the appropriate and official contact information for the clinic or hospital, reinforcing that I'm always available to help during my working hours and that other staff members are there to support them as well. This approach effectively redirects the patient toward a professional solution while validating their desire for a connection and upholding the standards of care.
What is your process for documenting a change in a patient's behavior and communicating it to the interdisciplinary team?
Documenting and communicating a change in a patient's behavior is a critical aspect of providing safe and effective care. My process is meticulous and follows a clear, structured approach to ensure accuracy and continuity of care. The first step is to observe and assess the change in behavior. This goes beyond a simple note and involves a detailed observation of the patient's actions, verbalizations, and nonverbal cues. For example, if a typically withdrawn patient suddenly becomes agitated and restless, I would note the time, the specific behaviors, e.g., pacing, clenched fists, rapid speech, and any potential triggers. This initial assessment is crucial for providing context. Next, I would document the observation immediately and accurately in the patient electronic health record. I use a factual and objective tone, avoiding subjective language or assumptions. My documentation would include the date, time, a clear description of the behavior, any interventions I implemented, such as de-escalation techniques or offering a quiet space, and the patient's response to those interventions. This detailed record serves as a legal document and a vital part of the patient's clinical history. The final and most important step is effective communication with the interdisciplinary team. I would not wait until the end of my shift to report a significant change. I would immediately communicate the change to the charge nurse and, if the change is clinically significant or poses a safety risk, directly to the psychiatrist or doctor on call. During team handovers or rounds, I would provide a concise SBAR, situation, background, assessment, recommendation report. This ensures that everyone on the team is aware of the change, understands its potential implications, and can collaboratively adjust the care plan. This systematic process ensures that all team members are on the same page, leading to timely and appropriate interventions that prioritize patient safety and well-being.
How would you use therapeutic communication with a patient who is experiencing hallucinations?
Engaging in therapeutic communication with a patient experiencing hallucinations requires a very careful, non-confrontational approach that prioritizes their safety and builds trust. The first step is to establish a calm and supportive environment. I would approach the patient gently, introduce myself clearly, and use a calm, steady tone of voice. I would not argue with the patient about the reality of their hallucination. Confronting them directly by saying, "That's not real," can cause them to become defensive, agitated, and less trusting. Instead, my response would acknowledge their distress and validate their feelings, while gently redirecting them toward reality. For example, if a patient says they hear voices, I might say, "I understand that you hear something, but I do not hear those voices right now. How are you feeling as a result of them?" My communication would focus on the patient's feelings and experiences rather than the content of the hallucination itself. I would ask open-ended questions to assess their level of fear, anxiety, or confusion, such as, "What are the voices telling you?" Or, "Are you feeling scared right now?" This helps me understand the emotional impact of the hallucination and allows me to intervene with appropriate support. Providing simple, clear, and concise instructions is also crucial, as their ability to process complex information may be impaired. I would use grounding techniques like focusing their attention on their immediate physical surroundings by asking, "Can you tell me what color my shirt is?" Or "Let's take a deep breath together." Finally, I would ensure to communicate with the rest of the care team about the patient's experience. Documenting the type of hallucination, the patient's response, and the interventions used is essential for continuity of care. I would continue to maintain a consistent and reassuring presence, offering comfort and security. My ultimate goal is to help the patient feel safe and understood, which is the foundation for any further therapeutic intervention.
Describe a time you had to advocate for a patient's rights when their treatment plan was in conflict with their stated wishes.
The core of patient advocacy lies in ensuring a patient's voice and autonomy are respected, especially when their wishes conflict with a proposed treatment plan. A specific instance comes to mind involving a geriatric patient with a chronic, debilitating illness who was facing a series of aggressive and invasive procedures. While the medical team was focused on prolonging his life, the patient repeatedly expressed to me his desire for palliative care and a focus on comfort rather than a cure. He felt the treatments were diminishing his quality of life and causing him more suffering. Recognizing this conflict, my first step was to validate his feelings and ensure he felt heard and understood. I confirmed his wishes privately and without coercion to make sure his decision was informed and his own. I then approached the interdisciplinary team, including the attending physician and social worker, with this information. I presented his perspective calmly and factually, not as a challenge to their medical judgment, but as a critical piece of patient-centered information that needed to be integrated into the care plan. I highlighted his repeated statements and his clear desire to prioritize comfort and dignity. This required navigating a delicate conversation, emphasizing that while their proposed plan was clinically sound, it did not align with the patient's goals of care. I facilitated a team meeting where we collaboratively reviewed the patient's chart, and I advocated for a shift toward a palliative approach. The outcome was a revised care plan that honored the patient's wishes. He was transitioned to a comfort-focused regimen, which significantly improved his mental and emotional well-being in his final months. This experience reinforced the importance of the nurse's role as the patient's primary advocate and the ethical obligation to champion their autonomy, even when it is a difficult conversation.
What strategies would you use to manage a situation where a patient is refusing their medication, and what are the ethical considerations?
Managing a patient's refusal of medication is a common and complex situation that requires a blend of therapeutic communication, patient advocacy, and ethical reasoning. My first step is always to understand the reason for the refusal. A patient's refusal is often not a simple act of defiance, but an expression of fear, side effects, misunderstanding about the medication's purpose, or a lack of trust. I would approach the patient calmly and non-judgmentally, asking open-ended questions like, "Can you tell me what's on your mind about taking this medication right now?" Or, "Are you worried about any side effects?" This approach fosters open dialogue and helps me pinpoint the underlying issue. Based on their response, I would use targeted therapeutic communication. If they fear side effects, I would provide clear, easy-to-understand information about the medication, its benefits, and how we can manage any adverse reactions. If they don't understand why they need it, I would explain its role in their overall treatment plan in simple terms, connecting it to their personal health goals. I would also offer them a sense of control by giving them choices where possible, such as choosing the time of day to take it or the form of administration. Ethically, this situation is a balance between a patient's autonomy and the nurse's duty to provide care and prevent harm. A patient with the capacity to make decisions has the right to refuse treatment. Therefore, if the patient is competent and their refusal does not pose an immediate and severe risk to themselves or others, I would respect their decision. However, if their refusal is clearly a result of their mental illness, for example, a patient with schizophrenia refusing medication due to paranoid delusions, and they pose a risk to safety, I have an ethical duty to intervene. In such a case, after documenting all my attempts at therapeutic persuasion, I would escalate the situation to the psychiatrist and the interdisciplinary team to consider alternative strategies, including involuntary treatment if it is legally and clinically justified. I would document every step of this process to ensure transparency and accountability.
How do you manage your own mental and emotional well-being to prevent burnout in a high-stress environment?
Preventing burnout in a high-stress nursing environment is crucial, and it requires a proactive and multifaceted approach. I prioritize my mental and emotional well-being by consciously separating my professional life from my personal life. At the end of a shift, I make a deliberate effort to leave work-related stressors behind. This might involve a simple ritual like listening to a specific podcast on my commute home or practicing a few minutes of mindfulness meditation to decompress before I enter my home. This clear boundary helps me recharge and be fully present with my family and in my personal life. In addition to this, I found that maintaining a healthy lifestyle is non-negotiable for my resilience. This includes ensuring I get adequate sleep, as it's the foundation for both physical and mental recovery. I also prioritize regular physical activity, whether it's going for a run or a yoga session, as it's an excellent way to release tension and clear my mind. Nutrition also plays a significant role. I focus on eating well to maintain my energy levels and overall health. Another key strategy is building a strong support system. I regularly connect with trusted colleagues who understand the unique challenges of our profession. We often debrief after particularly difficult shifts, sharing our experiences in a confidential and supportive space. This peer support helps normalize feelings of stress and prevents me from feeling isolated. Outside of work, I make time for hobbies and activities that bring me joy and a sense of purpose beyond my job, such as gardening or painting. These outlets are vital for fostering a sense of identity that isn't solely tied to my role as a nurse. By consistently implementing these strategies, I ensure that I'm not just surviving but thriving, which ultimately allows me to provide the best possible care to my patients.
Tell me about a time you had to deal with a conflict among staff members regarding patient care and how you resolved it.
Resolving conflicts among staff regarding patient care requires a focus on communication, collaboration, and most importantly, patient safety. The time I had to navigate such a conflict involved a disagreement over a patient's pain management plan. A junior nurse felt that the patient, who had a history of substance abuse, was receiving too much opioid pain medication and voiced her concerns directly to the patient's family, causing alarm. The charge nurse, who had approved the medication based on the doctor's orders, felt that the junior nurse had overstepped her boundaries and was undermining the care team. Recognizing the potential for a hostile environment and a breakdown in patient trust, my first step was to de-escalate the situation. I approached both nurses individually and calmly listened to their perspectives. I validated the junior nurse's concern for patient safety, acknowledging that her intentions were good, while also explaining the importance of following the prescribed care plan and using the proper channels for communication. I also spoke with the charge nurse, reassuring her that the junior nurse's actions, while inappropriate, stem from a place of concern for the patient's well-being. After these individual conversations, I facilitated a brief private meeting between the three of us. My role was to mediate and refocus the discussion on the patient's needs. We reviewed the patient's chart together, discussing the rationale behind a pain management plan and the safeguards in place to prevent misuse. I encouraged the junior nurse to voice her concerns directly to the team in the future and reminded the charge nurse of her role in mentoring junior staff. The resolution was a clear agreement. The junior nurse would trust the care plan and follow the chain of command, while the charge nurse would be more open to her concerns. The conflict was resolved, and the team's cohesion was restored, ensuring the patient's pain was managed effectively without further disruption. This experience taught me the importance of proactive communication and mediation in maintaining a positive and safe working environment.
How do you stay informed about the latest psychotropic medications and their potential side effects, especially with new FDA approvals?
Staying informed about the latest psychotropic medications and their potential side effects, particularly with new FDA approvals, is a continuous and multifaceted professional responsibility. My approach involves a combination of formal education, professional networks, and reliable online resources. I prioritize this because new medications and evolving research can significantly impact patient care, and a psychiatric nurse's role is to ensure that patients are both safe and receiving the most effective treatment available. First and foremost, I rely on continuing education. This includes attending webinars, workshops, and conferences focused on psychiatric pharmacology. Many professional organizations, such as the American Psychiatric Nurses Association, APNA, and other international nursing bodies, offer specific courses and continuing nursing education, see any credits that are tailored to the latest advancements. These platforms often provide in-depth analysis of new drug mechanisms, efficacy studies, and emergent side effect profiles, allowing for a deeper understanding than just reading a news headline. Secondly, I consistently utilize reputable medical databases and journals. I have subscriptions to or access through my employer to platforms like PubMed, the Lancet Psychiatry, and the Journal of Clinical Psychiatry. I also make it a point to regularly check official regulatory websites, such as the FDA's drug approval section, for press announcements and prescribing information for newly approved medications. These sources provide the most accurate and up-to-date information on indications, contraindications, and potential adverse reactions. For quick reference at the bedside, I use trusted mobile apps like Epicrates or UpToDate, which are regularly updated with new drug information. Lastly, I believe in the power of interdisciplinary collaboration. I make it a practice to actively participate in team rounds and case conferences where new treatment modalities are often discussed. I also feel comfortable reaching out to our hospital's clinical pharmacist or the attending psychiatrist to clarify any questions I have about a new medication or to discuss a patient's response to it. This collaborative approach ensures that I not only stay informed but also have a network of colleagues to consult with, reinforcing patient safety and best practice. By combining these strategies, I ensure my knowledge remains current, directly translating into better care for my patients.
What role do you see technology, such as electronic health records or telehealth, playing in the future of psychiatric nursing?
I see technology playing a transformative and essential role in the future of psychiatric nursing, particularly through the enhanced use of electronic health records, EHRs, and the expansion of telehealth. These tools are not just about efficiency. They're about improving patient care, communication, and accessibility. Electronic health records, for instance, are becoming more sophisticated, allowing for more detailed and integrated documentation of psychiatric symptoms, medication responses, and treatment plans. In the future, I believe EHRs will have more advanced features, such as predictive analytics to identify patients at higher risk of relapse or self-harm, allowing nurses to intervene proactively. A unified, easily accessible record across different care settings ensures that a patient's full mental health history is visible to every provider, which is especially critical for those with complex or co-occurring disorders. This reduces the risk of fragmented care and enhances team collaboration, as we can all view real-time updates on a patient's status and progress. Telehealth, on the other hand, is a game-changer for accessibility. For many patients, the stigma associated with seeking mental health care or the barriers of geography and transportation can be significant. The future of psychiatric nursing will involve nurses conducting follow-up appointments, medication management checks, and even initial assessments via secure video calls. This allows us to reach patients in rural or underserved areas and provide consistent care to those who might otherwise fall through the cracks. It also provides a unique opportunity to see a patient in their own environment, which can offer valuable insights into their daily life and living situation that a clinic visit simply cannot. The future of psychiatric nursing is thus deeply intertwined with technology, which will empower us to provide more connected, precise, and accessible care to those who need it most.
How do you ensure that cultural competence is a core part of your patient interactions and care plans?
Ensuring cultural competence is a fundamental aspect of my nursing practice, and I approach it as an ongoing process of learning and self-reflection. It begins with a commitment to self-awareness, recognizing my own cultural beliefs, biases, and assumptions. By understanding my own perspective, I can better avoid projecting it onto my patients. My goal is to approach every patient as an individual with a unique story, not as a representative of a particular culture or stereotype. During patient interactions, I use an open and inquisitive communication style. Instead of making assumptions about their beliefs or practices, I ask questions that invite them to share what is important to them. For example, I might ask, are there any cultural or spiritual practices that you'd like us to be aware of while you're here? Or how do you and your family typically approach health and healing? This helps me understand their specific needs and values regarding diet, family involvement, modesty, or end-of-life care. I also make a conscious effort to understand nonverbal cues and communication styles, as these can vary significantly across cultures. This knowledge directly informs the development of a personalized care plan. I integrate the patient's cultural beliefs and preferences into the plan to make it more effective and respectful. For instance, if a patient's family plays a central role in decision-making, I would include them in discussions with the patient's permission. If a patient adheres to a specific dietary practice, I would collaborate with a dietary team to accommodate it. I also make sure to use a professional interpreter when there is a language barrier, rather than relying on family members to ensure accurate communication and patient privacy. In essence, my process is about moving beyond cultural awareness to active cultural humility, a lifelong commitment to learning from patients and respecting their unique cultural identity as a vital component of their holistic care.
Describe your experience working with different age groups and how your approach to care differs.
My experience has provided me with the opportunity to work with a diverse range of age groups, from adolescents to geriatrics, and I've learned that a one-size-fits-all approach to nursing is ineffective. My care strategies are always adapted to meet the unique developmental, psychological, and physiological needs of each patient group. With adolescents, my approach is focused on building trust and establishing a collaborative partnership. This age group is particularly sensitive to being heard and respected. I prioritize open, non-judgmental communication and emphasize their autonomy by involving them in their own care decisions as much as possible, while still ensuring they understand the importance of adherence. I also recognize that peer influence and family dynamics play a huge role, so I am mindful of these factors when educating both the patient and their family. Conversely, my approach with geriatric patients centers on patience, respect, and a holistic view of their health. This group often has multiple comorbidities and complex medication regimens, so a thorough and systematic assessment is paramount. I focus on promoting their independence and dignity, even when providing assistance. For example, when educating an older patient, I might use larger font sizes on printed materials, speak clearly and at a moderate pace, and ensure they have their hearing aids or glasses. I'm also acutely aware of the risk of polypharmacy and potential for cognitive impairment, so I'm vigilant in monitoring for subtle changes in their physical and mental status that might signal a decline or an adverse drug reaction. Furthermore, I prioritize including family or caregivers in the care plan, as they are often a crucial part of the patient support system. This adaptability ensures that every patient, regardless of their age, receives compassionate, safe, and effective care tailored to their individual needs. How do you handle situations involving involuntary commitment or a patient's rights to refuse treatment? Handling situations involving involuntary commitment or a patient's right to refuse treatment requires a deep understanding of both ethical principles and legal protocols. My initial approach is to ensure the patient's autonomy is respected to the fullest extent possible. I would first assess their capacity to make a rational, informed decision. I'd engage them in a therapeutic conversation to understand their reasons for refusal and explore any fears, misunderstandings, or side effects that might be influencing their decision. My role is to provide clear, unbiased information about the medication or treatment, its purpose, and the potential consequences of refusal, empowering them to make the most informed choice. If a patient with the capacity to make a decision continues to refuse, I must respect their right to do so. In these cases, my advocacy shifts to ensuring their comfort and safety while documenting the refusal thoroughly. However, the ethical and legal landscape changes dramatically with involuntary commitment. This is a measure reserved for situations where a patient is deemed a clear and imminent danger to themselves or others due to their mental illness. In such a scenario, the principle of beneficence, acting in the patient's best interest, overrides autonomy. My responsibility is to ensure the patient's immediate safety and follow the established legal procedures for involuntary hold. This involves documenting all observations, a detailed account of the patient's dangerous behavior, and the rationale for the commitment. I would then communicate with the rest of the care team, including the psychiatrist and legal counsel, to ensure all procedural requirements are met. Throughout this process, I maintain a calm, non-confrontational demeanor, explain each step to the patient in simple terms, and offer as much comfort and reassurance as possible. My ultimate goal is to provide compassionate care, protect the patient and others from harm, and ensure that their rights are upheld within the confines of a complex legal and ethical framework.
What are your responsibilities as a psychiatric nurse in protecting patient confidentiality in a world of shared electronic records?
My responsibilities as a psychiatric nurse in protecting patient confidentiality in a world of shared electronic records are both ethical and legal. The core of this responsibility is to be a vigilant guardian of a patient's sensitive information. This means I must always adhere to the principle of need to know, which dictates that I only access and share a patient's record with other healthcare providers who are directly involved in their care. It is a fundamental violation of trust and privacy to view a record out of curiosity or for any reason not directly related to my role in their treatment. I am also acutely aware that psychiatric information is particularly sensitive and, in many jurisdictions, is granted an even higher level of protection than general medical information. In a shared electronic records environment, my responsibilities extend to securing this information. I am accountable for my personal login credentials and would never share my password with a colleague, no matter the circumstance. I must also ensure that I log off from a computer before leaving it unattended to prevent unauthorized access. When discussing patient information, even with a member of the care team, I'm careful to do so in a private setting where others cannot overhear, such as a closed office or a quiet area, and avoid public spaces like hallways or elevators. My role also involves educating patients about the nature of electronic records and the safeguards in place to protect their information. This transparency builds trust and empowers them to be active participants in their own care. I would explain who can access their records and for what purpose, as well as their rights to request copies or corrections. Ultimately, the shift to shared electronic records does not diminish my responsibility. Rather, it elevates the need for constant vigilance and adherence to professional standards to ensure that every patient's privacy is respected and protected.
How would you handle a situation where you suspect a colleague is not providing appropriate care or is violating professional boundaries?
Navigating a situation where I suspect a colleague is not providing appropriate care or is violating professional boundaries requires a careful, ethical, and professional approach. My first step would be to gather factual, objective information. It is crucial to distinguish between a minor error and a pattern of behavior that compromises patient safety. I would avoid making assumptions and instead focus on what I have directly observed or what has been reported to me. This might involve reviewing patient charts for inconsistencies, observing the colleagues' interactions with patients, or checking if their actions align with established hospital protocols. This initial step ensures that my concern is based on evidence rather than a personal judgment or a rumor. After gathering the necessary information, my next step would be to address the issue directly, but professionally, following the established chain of command. I would approach my immediate supervisor, such as the charge nurse or nurse manager, in a private setting. The conversation would be fact-based and non-emotional. For example, I would say, "I'm concerned about a potential patient safety issue. I've observed a few instances where patient X's pain medication was not documented correctly, and I wanted to bring it to your attention." This approach shifts the focus from accusing a colleague to solving a potential patient safety problem. I would also clearly articulate my concerns regarding any suspected boundary violations. These might include a colleague sharing personal information with a patient or engaging in a relationship that could compromise their professional judgment. It is vital to report these to a supervisor, as maintaining professional boundaries is a cornerstone of safe and ethical nursing practice. My role is not to be a judge, but to act as a patient advocate and a gatekeeper for professional standards. By following this protocol, I ensure that the patient's best interests are served while upholding the integrity of the healthcare team.
How do you educate patients and families on the difference between mental health disorders and normal emotional responses to life stressors?
The distinction between a mental health disorder and a normal emotional response to life stressors is a fundamental concept to clarify with patients and their families. My approach is to use clear, accessible language and relatable analogies to demystify complex psychological concepts. I begin by validating their feelings, acknowledging that everyone experiences stress, sadness, and anxiety as part of life. This creates a safe space for the conversation. Then, I introduce the key differentiating factors: duration, intensity, and impact on daily function. I explain that a normal emotional response is typically proportional to the stressor and temporary. For instance, feeling sad and withdrawn for a few weeks after a significant loss is a normal grief response. However, a mental health disorder is different. I describe it as a more pervasive and persistent condition, where the symptoms are disproportionately intense and prolonged, often lasting for months or even years. The most crucial point of distinction is the impact on daily life. I would explain, for example, that while a normal response might be difficulty sleeping for a few nights, a disorder might cause severe insomnia that prevents them from going to work or school for an extended period. I use a simple analogy. Think of a temporary emotional response as a small wave, while a mental health disorder is a powerful, ongoing current that can pull you under and make it hard to swim. My goal is not to diagnose, but to educate and empower. I would use visual aids or simple handouts to illustrate these points, and I would encourage both the patient and the family to ask questions. I would also reinforce that mental health disorders are legitimate medical conditions, not a sign of weakness. This approach helps reduce the stigma and encourages them to view treatment, whether it be therapy or medication, as a viable and necessary step toward regaining control over their lives.
Describe a time when you experienced a significant professional setback or disappointment and how you responded to it.
A significant professional setback I experienced was when a patient I had been caring for with a severe eating disorder relapsed, despite what I believed was a very strong therapeutic alliance we had built. I had invested a great deal of time and emotional energy into her recovery, and when she was readmitted to the hospital, I felt a deep sense of failure and disappointment. It was a disheartening moment that made me question my effectiveness as a nurse. My initial response was to feel discouraged, but I knew I couldn't let that emotion cloud my professional judgment. I took some time for self-reflection to understand what went wrong, but instead of focusing on personal blame, I shifted my focus to a systemic analysis. I realized that my disappointment stemmed from an unrealistic expectation that I alone could fix the patient. I had overlooked the powerful and complex nature of her illness and the external pressures she was facing. To respond constructively, I made two critical changes to my practice. First, I sought supervision from a senior nurse and a psychologist on our team. I openly discussed my feelings of disappointment and, more importantly, asked for their guidance on my approach to care for patients with chronic relapsing conditions. Their insight helped me understand that a relapse is not a failure of care but a feature of the illness, and that my role is to provide unwavering support, not to guarantee a specific outcome. Second, I adjusted my care strategy for this patient. I placed a greater emphasis on collaborating with the interdisciplinary team and involving the patient more in setting smaller, more achievable goals. We shifted the focus from a rigid cure to a more sustainable, long-term management plan that incorporated realistic expectations. This experience taught me a profound lesson in resilience and reinforced the importance of humility, continuous learning, and teamwork in psychiatric nursing.
What is your understanding of the use of physical and chemical restraints, and when is their use appropriate?
My understanding of physical and chemical restraints is that they are interventions of last resort, to be used only in situations where a patient poses an immediate and serious risk of harm to themselves or others. This is a core principle of international nursing standards and is rooted in the ethical and legal obligation to protect a patient's autonomy and dignity. The use of a restraint is never a matter of convenience or punishment. It is a critical safety measure, and its application must be strictly governed by protocol. Before any form of restraint is considered, a nurse must exhaust all less restrictive alternatives. This includes using therapeutic de-escalation techniques, providing a calm environment, offering distraction, and engaging in verbal communication to diffuse the situation. If these interventions fail and the patient's behavior escalates to a point where they are at risk of self-injury or harming others, I would consult with the interdisciplinary team and the attending physician to make a shared decision. The patient's rights and safety remain paramount. When a restraint becomes necessary, its application must be carefully documented and carried out with an absolute focus on patient safety. This includes documenting the specific behavior that necessitated the restraint, the less restrictive measures that were attempted, the type of restraint used, and the patient's response. Continuous monitoring of the patient's vital signs and physical and psychological well-being is mandatory. The restraint should be removed as soon as the patient's behavior is under control and the immediate risk is past. The use of chemical restraints, such as sedatives, follows the same strict principles. It must be a physician's order and only used when clinically justified to prevent harm. Ultimately, the goal is always to return the patient to a state of safety and control with the least amount of restriction necessary.
In the context of the opioid crisis, how would you address a patient's pain management needs while being mindful of their mental health history?
Managing a patient's pain in the context of the opioid crisis requires a balanced approach that is both compassionate and cautious, especially when they have a co-occurring mental health history. My first step is always to conduct a thorough and holistic pain assessment. This goes beyond a simple pain scale rating and includes exploring the patient's full medical and psychiatric history, their substance use history, their coping mechanisms, and their personal beliefs about pain and medication. A patient with a history of anxiety or trauma, for example, might experience pain more intensely or have a fear of dependency, so understanding these psychological factors is crucial. I would then advocate for a multimodal, non-opioid first pain management strategy. This means prioritizing non-pharmacological interventions such as physical therapy, hot and cold compresses, distraction techniques, and relaxation exercises. I would also explore non-opioid medications like NSAIDs or acetaminophen. My goal is to use opioids only when absolutely necessary and in the lowest effective dose for the shortest duration. If an opioid is required, I would ensure to communicate this plan clearly with the patient and family, setting expectations about the short-term use and the tapering process. Throughout this process, continuous monitoring and open communication are paramount. I would regularly reassess the patient's pain level and their response to the interventions. Equally important is monitoring for any signs of misuse or diversion without being judgmental. My conversations would be empathetic and non-stigmatizing. For a patient with a mental health history, I would also collaborate closely with the psychiatric team to ensure their mental health care plan is integrated with their pain management. This dual-pronged approach ensures that we are not only treating the physical pain, but also safeguarding the patient's mental well-being and mitigating the risk of opioid dependency.